Fantastic. It's really my honor and pleasure to introduce Sandro Rizoli. Most of us in this room know Dr. Rizoli for quite some period of time. I'm not going to go into his academic accomplishments in detail other than to say he was originally trained in Brazil, and we were lucky enough to keep him in Canada after his fellowship. Sandro is really, I would say, one of the defined thought leaders in Canada with regard to not only resuscitation and coagulation, but trauma in general. He's someone that in the Canadian and really the international context, when he speaks, we quiet down and pay attention because he's usually giving us some pretty great insights. Today he's going to talk to us about beta blockers, in particular with reference to traumatic brain injury. As you know, this is really quite a hot topic, and he's moving forward quite rapidly with it. So thank you, Sandro.
Thank you very much, Dr. Ball, and I want to thank all the organizers of this meeting for the honor to be invited to be here with you. Usually I have a nice picture of Toronto in the summer that I show on all my presentations, but today, for those who are here, I don't have that picture. So just look outside and you're going to see my beautiful city and how beautiful summer really is here, right, in Toronto, right? All wet and dumpy and rainy. Okay, so let's talk about beta blockers and head injury. So these are my disclosures, nothing really to disclose. The first question is, does it make sense to use beta blockers in patients with head injury? So our species has survived because when we are under threat, we have this storm, this massive release of catecholamines that can be summarized as in the fight or flight. So when you're traumatized, injured, our species gets in that mode of fight or flight. And that's all catecholamine response. And that's how we have survived. That's why we have taken over Earth. So does that make sense now to talk about a drug that actually blocks this catecholamine response? So this catecholamine response makes our heart goes faster, increase our blood pressure, increase fuel to our cells, dilate our pupils. At the same time it dilates our pupils, it makes our vision more tunnel. So we're more fixed on one objective at that time. It sends more blood to our muscles. It basically boosts us from energy. Is that right? That if we give a drug that blocks all this, we're going to do benefit to our patients? So that's the question I'll try to address in the next 30 minutes or so. So let's start talking a little bit about the particular trauma I was asked to talk, and that's head injury. So head injury can be summarized in one word: it's devastating. In Canada alone, and remember, Canada doesn't have 40 million inhabitants, right? You're in the biggest city of this country now, that's Toronto, that's it. Still, here in Canada, about 450 Canadians every day suffer a head injury. That's too many. So it's devastating, it's common. So about 165 people in Canada alone, we have 30 times more people with head injury than we have people with breast cancer. So it's very common. It's very impairing. Patients who suffer head injury is the most common cause of mortality, most common cause of disability, and is extremely, extremely costly, not only to the people who suffer the head injury, but to the society in general. And let's talk about head injury. We haven't seen many advances recently. In fact, the only advance we have seen are guidelines. Our standardization. That's the only things that have changed, actually. There's no new drug for head injury in the last 50 years. There's nothing new. They're just standards and guidelines and protocols. That's where we have advanced. And the evidence supporting anything in head injury is lacking. And this is how trauma causes injury to the brain. There's initially a primary insult. There's a direct damage to the neuronal cells, to the axons. There's an impairment of blood. There's necrosis. There's death. So that's the primary insult. But the consequence of head injury is the sum of the primary and the secondary insult. And the secondary insult, for example, is hypotension. So if hypotension occurs, you have more damage now being caused to already an area that has been injured. And that's the sum of it who's going to say how this patient is going to survive this injury. And the fact is, this catecholamine storm is part of the secondary insult. Actually, it can be, right? We're going to be talking about catecholamines actually being neurotoxic, being damaging to the heart, causing vascular collapse, and actually worsening the primary insult. So the first thing here, the first conclusion, we're going to have a few short conclusions so I can try to keep you all awake while we go through this, is that the first conclusion is our species has survived because every time we're threatened, every time we're injured, every time we're traumatized, we have this massive release of catecholamines. So that's a survival. That's beneficial. Right? However, can maybe something good, when in excess, be harmful? So let's go and look. So 2 years ago, I was invited to talk at this meeting, and at that time I presented a thesis of one of my students, and I'll be talking about it. But remember that when you have a patient with head injury, this massive release of catecholamines is basically to try to preserve the brain and the heart. So how can it cause damage to exactly what it's trying to preserve? The fact is that as the catecholamine storms increase the blood flow to the brain, certain parts of the injured brain have lost its vasoregulation. So actually more blood going to an injured area may actually cause more edema. More edema can increase the intracerebral pressure and can cause more ischemia to the brain. So that will be one of the mechanisms. And then there's also damage of the catecholamines to the heart and to the vascular system as well too. Please note that I'll be talking about early catecholamine response. I'm not going to be talking about the ICU, paroxysmal, adrenergic response that occurs later on. Right? This is early sympathetic adrenal response. Okay, so let's talk about the COMA study that, as I mentioned to you, I gave you a preliminary idea 2 years ago at this meeting. This was a study just to measure adrenaline and noradrenaline levels in patients with isolated head injury. This was done in 3 hospitals. Was done at St. Michael's Hospital where I work, was done at Sunbrook Hospital, just a few kilometers north of here, and was done at LA with Dr. Kenji Inaba. So basically got all patients, adult patients that came in, moderate to severe head injury, off the street, isolated head injury, and we measure catecholamine the first 24 hours. And then what we did, we tried to do an association between catecholamines and outcome. So then we measure functional outcome. Remember, we're talking about head injury. Just being alive is not enough. You have to be alive and have a good neurological recovery. And then we made an association between them both. We followed almost 180 patients. That was our goal. And we found out that more than 60% of our patients, because they had moderate to severe head injury, they actually had a poor, an unfavorable outcome. Unfavorable outcome includes death as well too. So this is one of the things that we learned, and this is already published this year. What we found out is that the release follows a pattern. And this release is massively initially, and then it falls. It drops, right? So, and that's very constant for both epi and for norepi. And then we made a correlation between epi and norepi levels and poor outcome, that includes death, and there's a direct association. The peak, the highest amount of epi and norepi released is associated with how poor these patients do. There's a clear association. It's not how fast it drops, it's not if it maintains high, it's not, no. It's the peak, it's a dose response. The more epi norepi they have released, more likely they are to have a poor outcome. So conclusion number 2, conclusion number 1 was Yes, our species has survived because we have this sympathetic storm when we're injured. Second of all, maybe some patients have an exaggerated response. Too much epi-norepi after a head injury is harmful. It worsens the outcome of these patients. Okay? Question is, how much is this exaggerated response? So I'll talk to you about a few mechanisms. So if you pay attention to this slide, the rest you can take a snooze, right? You can check your telephone. So I'll propose that the way that an excessive release of adrenaline and noradrenaline, what they do, they actually cause brain ischemia. They actually cause edema in the injured parts of the brain. They actually increase the oxygen demands by the brain and the heart that cannot be met. And then there's an increase of metabolic demands of the entire body, and that adrenaline and noradrenaline drive inflammation. Okay, so let's look at the evidence behind all these assertions. So before, let me talk a little bit about what catecholamines are. Right? And it's just because I have time, I'll just refresh, first year medical school. Catecholamines are hormones. They're also neurotransmitters, and they basically work through different receptors, the beta receptors and the alpha receptors. So the beta receptors, actually, the two people that described the beta receptors won a Nobel Prize, right, in 2012 for their description of the beta receptors and how they function. So the beta receptors are G protein receptors, and then they activate adenyl cyclase that then activates protein kinase A, and actually has a negative effect on the receptors. So it's a cycle. Epinephrine is primarily coming from the adrenal medulla, while norepi comes mostly as a spillover of the sympathetic nerve endings. Right? Epi and norepi have about the same potency, the same as strong as each other, but different receptors respond differently to epi and norepi. Okay, so that's enough on basic science. We have beta receptors, we have alpha receptors, and I was actually surprised. I was looking for a map of the brain, trying to see where do you have more beta, more alpha receptors, and so on. I couldn't find it, but we know beta 1, particularly in the brain, cause increased inotropism, chronotropism, and cardiac output. In the blood vessels, beta 2 receptors cause vasodilatation, bronchodilation. And then alpha receptors cause vasodilatation in certain beds, particularly in the brain, while alpha stimulus may cause vasoconstriction. And actually, when I try to understand what happens in the brain, if I give epi nor epi, the answer is it's complex. It's going to be a balance between vasoconstriction and vasodilation. And actually, again, as I said, I was surprised that it doesn't exist a map of the brain with all the beta and alpha receptors. Or I couldn't find it. If you find it, please send it to me. I'll be very interested. So this is one study that shows that epi cause ischemia to the brain. So this was studying pigs. So they cause VFib arrest in pigs and start doing CPRs, just like we do in our patients, and then you give epi as part of the CPR. And then they measure the blood flow to the brain. What they saw, the big vessels, big flow, little vessels, microcirculation, completely shut down. So when you give epi, you kickstart the heart, but you cause microischemia in the cortex of the brain. Okay? And that's one of the reasons why today we're asking whether we should give epi when we do CPRs. It's in part because of this study published in 2009. Right? So, and the levels of epi in patients getting external epi during CPR are about the same that we measure in our patients with head injury. Right? So it's the same thing, it causes ischemia. The other thing that it causes, I mentioned earlier, you lose your vasoregulation of the brain. Right? The injured parts of the brain now, the vessels cannot contract. This storm of catecholamines increase blood pressure, increase cerebral blood flow, but you need some regulation in the injured areas, and you lose it. So now I have this massive amount of blood coming in, leaking outside of the vessels and causing edema, increasing ICP, and causing even more ischemia to the injured brain due to edema. Right? It's interesting that one of the protocols best well known to treat head injury is called the Lund protocol, and what they do, they give propranolol and they give clonidine. And what they want to do is reduce the volume of the brain, reduce the edema in the brain by decreasing the cerebral blood flow. Very interesting. But how about the heart? This massive amount, the release of adrenaline and so on, can actually cause myocardial necrosis. And that's interesting. Like Paula has some studies doing ultrasound in patients with trauma. And we know that many of our patients, they are hypotensive, they're not bleeding. And you say, what the heck is going on? And then Dr. Paula Ferrada comes with her echo, and she says he has Takotsubo. Surgeons now talk about Takotsubo, right? So Takotsubo is a cardiomyopathy induced by sympathetic overstimulus. You can't feel the left ventricle. And that's one of the reasons why some of our patients are hypotensive. It's a LV dysfunction caused by too much adrenaline, too much norepi. How many times have you rounded in the ICU and you've seen your patients that their fingers are black, and you say, what are you giving? And the intensivist is giving massive doses of norepi on this patient, and say, you know what, why don't we slow down this norepi, and your patient improves. Actually, their lactate decrease. So a lot of epi, norepi, can be harmful, and the heart is one of these. In our coma study, about 60% of the patients with isolated head injury had an abnormal ECG, had abnormal troponins. So the heart is hit bad by this storm, by the sympathetic storm. We know that catecholamines drive inflammation. We know this. I could bore you for hours, telling you all the known pro-inflammatory effects of adrenaline, noradrenaline. I'll just say isoproterenol. Isoproterenol is a beta receptor agonist. You can actually titrate inflammation by going up and down with isoproterenol in your animals. It's a beautiful pro-inflammatory drug, just like all the other ones. And then it also affects the immune response in the brain as well too, with some effects that might be beneficial, some effects that might be harmful. Of course, it affects coagulation. Excessive adrenaline or adrenaline causes endothelial damage. And the endothelium is key in the coagulopathy of trauma. It causes glycocalyx degradation. So actually, epi and norepi are involved with the coagulopathy of trauma that we see, and from the burn literature, there's plenty of evidence that epi and norepi are very catabolic hormones. Right? They cause a massive catabolism in your body, and your body now needs more energy to survive, and so on. That's not always met. So conclusion number 3, and we're going on time, is that survival depends on the catecholamine response. The coma study showed us that some patients have too much catecholamine. The more brain injury they have, higher the levels of epi and norepi they are released on these patients, and this excessive release is associated with worse outcome. And there's a lot of evidence that explains how actually too much epi norepi can cause damage to the brain, damage to the heart, damage to the entire body. Can cause ischemia to the cortex, can actually cause more edema in the injured parts of the brain. So now comes the question that I was asked to talk. Should we give beta blockers? I hope that by now you're saying, yes, of course, yes. So that's what I hope you're saying. If you're saying that, you're paying attention, so it's good. Okay, beta block. Okay, so another Nobel Prize, right? So one Nobel Prize was given to the person who described the beta adrenergic receptors. The second Nobel Prize was given in 1988 to, I think his name was Black, that he described what? He described propranolol, right? So he was the first effective beta blocker, and Dr. Black got a Nobel Prize for that. Okay, so let's talk about these fantastic drugs, beta blockers. Should we give beta blockers to patients with head injury? Yike. Good question. So just remember you that when you give beta blockers, you're going to block beta 1, beta 2, beta 3 receptors, depending on the drug that you give. If you give propranolol, you're going to block all of them. You can give selective blockers as well too. In the heart, the beta blockers are going to reduce atrial contractility, heart rate, conduction, going to increase the vasomotor tone of the coronaries, and it's going to have a negative inotropism, negative chronotropism, and will increase peripheral vascular resistance, meaning it will drop the blood pressure. On the lungs, if you give propranolol, you can cause bronchoconstriction, right? And those are the ones I got. In the brain, who knows what it does, right? We know that propranolol is one of the few beta blockers that actually cross the blood-brain barrier, and actually we give them for patients who are restless, agitated in the ICU to calm them down. I didn't take beta blockers before I came to give this speech, but many people do, so then they look cooler, right? So you take beta blockers and they cool you down. And they cool down. I prefer to use them on my hot patients in the ICU, when they are jumping out of the bed. So beta blockers have many effects. Many effects. So propranolol is non-selective beta. We have non-selective alpha and beta blockers, like labetalol is my favorite to manage patients that are having hypertensive crisis. And then you have beta-1 selectives like metoprolol that just work in the heart, for example. Okay? One thing we know, beta blockers not good for hemorrhagic shock. Not good. Right? Increased mortality. I'm not going to mention to you the studies, for goodness sakes. We all know that. How about what else do beta blockers do to the brain? So what they do actually, and those are beautiful studies by Eric Lay in particular, again, my colleague from Los Angeles, he showed in animals that actually if you hit the brain of a rat, a mouse, and you give them propranolol, you actually increase cerebral blood perfusion by 150%, and you decrease hypoxia by 24%. And actually, we saw there's studies showing a reduction in lactate after you introduce beta blockers as well too. So it's very interesting. So propranolol decrease oxygen demand, decrease CO2 production, normalize glucose metabolism, that's key to the brain, has a big anti-inflammatory effect. So this is a study by my colleague, Dr. DiBattista and Dr. Baker here from Toronto, was part of the COMA study. They look at the inflammatory response, and beta blockers do reduce inflammation, even systemic inflammation. It affects the metabolism. It decreases that catabolic state that those cells are in, and that hyperglycemic response of trauma. It includes muscle performance. There are models where actually they have of trauma where they do laparotomy, lung contusion, and they show that propranolol actually improves even lung contusion. Oh my gosh, it's good for everything. How about the coagulation? Does it affect coagulation? It does affect coagulation too. It in fact decreases fibrinolysis. And may have a direct effect on glycocalyx shedding and endothelial damage. And also, you know that anemia that you see in your patients in the ICU, and you think that's because you haven't given enough blood to them. Part of the anemia that we see post-trauma is bone marrow depression. There are actually studies on beta blockers reversing the trauma-induced bone marrow depression. So even for anemia, it's good. And also has an immunomodulatory effect and has a plethora of other effects that I'll not bore you through them, but I'll be very happy to send you all tons of papers. Most of those studies are all experimental. How about clinical studies? How about studies in humans? And I was very fortunate, as I was preparing this lecture here, this paper came out in Annals of Surgery. So this is Alali and Nathan's systematic review on beta blockers and head injury. Don't confuse, this is not the 2013 paper, this is a 2017 paper, fresh out of the stove, and basically what they showed is that all the retrospective data that exists, right, shows that there is benefit. Actually, patients with head injury that for whatever reason got beta blockers had a decreased mortality. Hey, at the end of the paper, there's a AAST recommendation that if you have a patient with head injury, you should consider using beta blockers. Okay, that sounds really, really good. And actually, there's a single randomized controlled trial on beta blockers in head injury. It was a study, an old study. They were just looking at how protective beta blockers are to heart damage caused by the head injury. And they showed that there is benefit, published in Lancet in 1987. And there are many other studies by my colleague, Brian Cotton, Inaba, and so many others. All small retrospective studies, low evidence, but they all show the same thing. The same thing as Alali and Nathan's is there's benefit, survival benefit to using beta blockers in trauma. And this is the paper by Eric Lay. Eric Lay is going to open the AAST this year. So if you go there, it's going to be the inaugural talk. And I called Eric, and I showed him my presentation and got his approval. So just so you know. And Eric, if you're seeing me here, that's just saying that I'm keeping to our contract, to our agreement. This is Eric's paper. So I'm just going to give you the big picture. I'll leave the hump for him at AAST. Eric led a group of 15 trauma centers across North America. We all shared our data with him, and he saw this: 1,800 patients who got any beta blocker and had a head injury, any beta blocker, for whatever reason beta blocker was given, these patients had a reduction in mortality. All right? The patients who got beta blockers were older. Many of them were already taking beta blockers before they came to the hospital. And if propranolol was used, the effect was even larger. So beautiful paper, one reason to go to AAST. But is that it? No problems using beta blockers, right? Beta blockers drop the blood pressure. So we know there are classical studies that say that if your patient with head injury has a single episode of hypotension, in the pre-hospital, what happens to mortality? How many times, Dr. Perry? Beautiful, beautiful, right on, go higher, right? So actually some studies show 2 times, but there's one study in the ICU showing 11 times increasing mortality. It doesn't matter how much it increases, right? So you're giving a drug that drops the blood pressure, drops the heart rate to a patient that cannot tolerate hypotension or bradycardia or hypoxemia. So there's the POISE study, and this is the end of my talk here, that I'll just remind you. This paper was published in Lancet just a few years ago. They gave metoprolol in the perioperative. So for our elective and emergent cases, they gave metoprolol, and they proved that metoprolol reduced perioperative heart attack, myocardial infarction, but increased mortality. That's why when we consult our internists, they don't prescribe beta blockers to our patients anymore going to surgery, right? Because of the POISE study that showed an increase in mortality. So right now what we have is retrospective evidence, weak evidence. But the evidence is building up, right? So I'll try to summarize everything now in the 2 minutes that I have left, and let's see if I can. I think that I still have your attention here, so that looks good. So everything I thought I said here, and I hope you heard. So there is a survival benefit to a sympathetic response. 2, the coma study, however, showed us that some patients have an exaggerated response. They release too much. And I hypothesize that the reason they release too much is that because the release is proportional to the brain injury. The more brain injury they have, the more their body turns on their adrenergic response. And this over-exaggerated response is associated with harm. In the coma study, was associated with worse neurological outcome and higher mortality. Right? And the reasons for that, we can come up from the evidence that we have. We know that adrenaline can cause microcirculatory ischemia to the cortex of the brain. We know it can increase edema in the injured areas. We know it can affect the heart. We know this. We see our patients, in the ICU with ECG changes, with the rhythm changes. We see them with cardiovascular collapse, like the Takotsubo syndrome, I just said this because we had a few recently, and I was impressed, like how common that thing is. I never heard of it before, and now I get, one a week explaining why my patients are hypotensive. So, and also adrenaline, noradrenaline, and the adrenergic hormones, they drive inflammation as well too. We know that beta blockers can block, actually they are very effective in blocking, and there's a lot of experimental data that shows that actually they would have a role to modulate this response, this exaggerated response. Right? And there's now a growing number of clinical evidence that suggesting that actually strongly that beta blockers actually may be in fact protective to patients with a head injury. The fact is there are many things that we don't know, right? So which beta blocker to use? When do I give the beta blocker? The coma showed that it's immediate, that massive release, and that's that release that's associated with poor outcome. So should I be giving propranolol in the ambulance? Right? Should I be giving what dose? Should I titrate the beta blocker to a certain heart rate? So I think that the stronger recommendation that you're going to get from me is that we need good studies, right? We need another proper study, but a proper study for maybe beta blockers and patients with head injury, right? So today the recommendation is if your patient is in the ICU, if your patient is being monitored, if your patient has a severe head injury, consider beta blocker for this patient. Right? Provided that you're sure that you're not going to cause hypotension or bradycardia for this patient. Right? So I think above all, we need very good studies. And once again, I thank you very much for the privilege of being here.